We all know the reason we are here. We are talking about endometriosis. Hopefully, the speakers will not waste time. The format of this meeting is to seamlessly go through presentation without interruption. If you don't know me, my name is Dr. Alabi. I'm the host today. I work for South Shore Women's and Children's Hospital, the organizer of this webinar.
All right, good afternoon, everybody. And thank you, Juwon and South Shore for inviting me to this talk to share experience about endometriosis with the public and some other doctors in Nigeria in creating awareness. My name is Dr. Adewale Folarin, as you know. I'm an obstetrician gynecologist in Princess Anne Hospital in Southampton. So I send my greetings to you from the Great Ocean View City, and you are all welcome to this presentation. My job today is to talk about the definition, pathogenesis of endometriosis, which you'll see along the way is a bit of a controversy even among those of us who are doctors. I have nothing to declare on this presentation, so I have no gains from it apart from imparting knowledge. Okay, so what is endometriosis? So endometriosis is when we have the functional tissue, which we know normally lines the normal part of the womb. That means the uterus, and it's growing in other parts of the body. As you can see from the picture here below, this area where I'm pointing to are some areas of endometriosis. You can see the womb, the fallopian tube, and the intestine around. That is just showing a laparoscopic view of the inside of a lady. So that is basically talking about, that's what he means by saying that's endometriosis. Where do we find endometriosis? Typically, the common place we find it is in the pelvis and in the woman's pelvis, but it can occur in other sites of the body, include the bowel, the urinary system, along the diaphragm, which is a sheet that separates the chest cavity from the abdomen. That means your chest from your lower tummy. The pleural cavity on rare occasions, and also in the brain. This had been recorded, and I could tell you about 2 months ago, we had to operate on somebody who has this debilitating thing in the chest. So if we say it's common in the pelvis, where do we find it commonly, and how often do we tend to find them? This picture trying to show you the picture of a female pelvic, which is the womb, the bladder, and then the bowel here. And these dots are the area you find endometriosis. And on this small area, on this here, we can see that the commonest place we found it is on the ovary, about 60 to 70%. And endometrioma, which is the chocolate cyst that forms on the ovary, occurs in situations about 30 to 40%. These are the other parameters where you can find it, and you can also find it behind the womb in about 20 to 30%, on the bowel in about 7%, and your intersacral ligament, which is a ligament behind the womb, in about 20 to 25% of cases. So how do we categorize endometriosis in talking about so we can find endometriosis just lying on the surface of the lining of the body, which is called the peritoneum, especially in the pelvic. So we call this superficial endometriosis. And we have ovarian lesions, which could just be on the peritoneum or the ovary, or forming a cyst, which is called chocolate cyst. I'm sure a lot of you will have heard about that. That is because the endometriosis is going deep into the ovary and is causing bleeding and blood collection inside the ovary and making it a painful situation that can also be related to infertility. And then we have the deep infiltrating endometriosis, which I'm sure some of my colleagues will talk about later on today, when the endometriosis is growing deep, more than 5 millimeters deep into the peritoneum. When does it affect? Okay, so we said it affects women. So basically, it's an estrogen-dependent thing. So around the period when a woman is supposed to have increase in their estrogen level. So because it's estrogen dependent, and we know it's not a cancer, so it responds to the hormone of the woman's menstrual cycle. So usually it can occur in premenarcheal, late, young girls, girls that are just about reaching the time they start becoming age of puberty, and in reproductive age when most you've started your period and the woman is in the childbearing age. Then the postmenopausal period, when the earlier part of it, when the hormone is just tailing off, but it's not totally gone. So we can actually, oh, you just achieved your menopause, so your endometriosis is totally gone now. It might take a little while before it goes away, and the symptoms may still be there. Okay, so what are the prevalence, or how common is endometriosis? Generally, it can affect anybody of any race. It's going to be a bit more common in the Caucasian population, but looking at it worldwide, it affects about 10% of women in their reproductive age group. And depending on the population you're studying, this prevalence might be higher. So some of the situation, where we've had studies done on people who have had surgery, you found that in 21% of women who are presenting with pain before their surgery, they tend to find endometriosis at the cause of the pain. In women who are not even asymptomatic, about 8 out of 100 of them will be found to have endometriosis being a silent thing happening to them. And when you look at women who are seeking fertility treatment, about 50%, the 30 to 50% of them will be found to have endometriosis being a problem. So now talking about how does it come about? That is the pathogenesis of it itself. How does it come about? How does it grow? So we know that endometriosis is the cell growing in, it has to grow, it has to come out of the womb, or one way or the other, find its way into other part of the body. It has to be able to implant itself. It has to be able to establish itself and elicit the response that will cause problems to women. And for more than 100 years that we've known about endometriosis, we don't totally know how this, and we can't explain fully how the endometriosis often come about in different women. We don't have full knowledge of it, but we know that it could be a combination of factors, more so multifactorial. But there are some theories that have been postulated and have been researched over the years, and these are the common ones that we know can explain why endometriosis come about. The number one theory that was first brought about, which was neglected for many years, it was in 1927 by Johnson A. Simpson, the retrograde menstruation theory. And then we have the coelomic metaplasia, which means changes in the cells that line the lining of the body, and what we call Mullerian rest cell. Mullerian is its set of structures that form the female genital system eventually. And bone marrow stem cell is now a new thing which in relation to the vascular and lymphatic dissemination of endometriosis, when we start finding endometriosis in very, very unusual place in the brain and in the chest. All right. Immunological problem, we found that people who have some autoimmune problems like Graves' disease have had to come up with having more situation of endometriosis than other. There are some genetic factors that have been identified and are still being studied, which predisposes other people to processing these cells, which are the cause of the problem. I'm going to talk about some of this theory so that we can have a better idea about them. The Sampson's theory, which is also called the implantation theory, it says that endometrial cell, when the woman is having their period, there's a backflow from the fallopian tube into the lining of the pelvis, the peritoneal cavity during menstruation. And then this can lead to endometriosis. The evidence from this was initially picked up because we found out that young girls who have problem of obstruction to the outflow of their menses, have increased incidence of developing endometriosis. But backflow of menses occur in more than 8 to 9 out of 10 women. About 90% of women will have some sort of retrograde menstruation. That means the backflow of their period. But not all of them develop endometriosis. So there must be some other thing that would suggest why women would develop endometriosis apart from this theory, definitely. And won't explain why some women will have endometriosis in premenarche period or have endometriosis in their chest or in the skull, in the brain. So what are the conditions that will be necessary for endometriosis cell to establish itself? First of all, if you go about with this implantation theory, we have to have retrograde menstruation happening. Even if retrograde menstruation happen, as I said, that 9 out of 10 women will have it, there must be cells that are active enough to establish themselves. So there must be viable endometrial cells and stroma that would, establish, that will be able to grow. That means able to have the ability to attach themselves, adhere onto the peritoneum, and eventually have something that aids them to implant into the peritoneum and then proliferate and grow along this area to establish a live cells that will continue to cause damage. So this is just giving you a pictorial thing of what I've explained about the retrograde menstruation theory. This is the womb cells which are active, passes through the fallopian tube. They implant themselves here, adhere to the cells, and then they start growing into the tissue. The coelomic theory, which is the other one of the theory I also mentioned, metaplasia, means that the coelomic cells are the cells which, from when the babies are growing, in utero, are the cells that has the potential to line the lining of the womb and line the lining of the body itself. So they could have some situation that would trigger them either through some inflammatory procedure or hormone that will make them transform themselves to start becoming endometriotic tissue. So this will explain that, anywhere where you have peritoneal tissue or peritoneal lining, metaplasia will explain, or the transformation can explain why this thing will start growing in the chest, start growing in the brain, as well as the bone marrow theory as well, also correlates to explain this further, because they both, there's what we call stem cell, which are like seeds of cells in the body that can regerminate in other places in the body, could also come about, exist, and then through the blood flow in the body and the lymphatic draining, which are other things that drain fluid from the body, can also transport this around the body to different parts of areas where we wouldn't expect endometriosis, and we have been finding them now. The other theory I mentioned is the Mullerian rest cell theory. The Mullerian tubercle and the Mullerian system are the system in when the baby is growing in the embryonic stage, where you can, these are the group of structures that eventually form the fallopian tube, the womb, and the neck of the womb as well. So this theory was established when they did autopsy on dead babies, and they were finding endometriosis in them. So this would sort of explain why this can be a possibility of how endometriosis come about. So as this track is being laid down when the baby is between 8 to 10 weeks, the structures, as I will show in one of my slides, is this is a baby, trying a pictorial representation, and this lining of the structure around the body of the baby is what develops to form the genital tract of the baby. And as they shrink along to rest in the pelvis, they can lay down some of their, so some of their cells that they leave behind as they're shrinking can eventually be triggered off later in response to either maternal hormone in the womb, or as the women start achieving menarche, then these cells can be triggered and they start growing in those areas where they have been left behind. So that's the potential of all these cells that that will explain the reason why endometriosis. So that is all I have to tell you about pathogenesis. I won't be able to go, otherwise I'll be boring you. And I know some of this will overlap with some of the talk from the other presenter. I wish us a safe deliberation today. And thank you all, and stay safe. I will be entertaining your question later on. Thank you.
Good afternoon, one and all. More so to the attendees, as well as to my fellow panelists. I'll also want to thank Dr. Juma Alabi for the kind invitation to share my experience with you. So I am Rotimi Jaiyesimi, obstetrician and gynecologist at Basildon University Hospital, I'm also the Associate Medical Director for Patient Safety in the hospital. I'm an NHS Patient Safety Specialist, as well as Adjunct Professor of Law at the University of Ibadan. That's the outline of what I will be talking about, and more specifically, it's how does it affect people and how is it diagnosed. Disclosures are just to say I'm the chair of my Gynae Issues Foundation, a foundation based in Nigeria. So that's the only expression of interest I'd like to declare. Now, one might ask, why do we have the spotlight on endometriosis? Why have we chosen endometriosis as a topic to discuss today? We've been told it affects about 10% of women in the reproductive age group. And when you look at that, you're talking of 176 million women. That's more than what we're crying about at the moment in terms of COVID-19 pandemic. Then one might question, why haven't we got the concerted effort to try and solve this problem? It does start from menarche onwards, and as you heard, it could go beyond the menopause, and it impacts the quality of life. And it does infect many organs, nerves, causing damage. And perhaps the most perspective is the delay in diagnosis, which is important. How does that affect people? The main issue is the pain it causes. Pain in the pelvis is the primary symptom of endometriosis, and it can be cyclical or non-cyclical. And it's usually worse during the menstrual period, and the pain could also be progressively worse. When you have your periods and you have pain, that's called dysmenorrhea. And endometriosis, we also know, causes painful intercourse. That's called dyspareunia. And when the pain is so severe that a couple decide not to engage in intimacy, that is called apareunia, when they don't have sex. Now, I believe that dyspareunia is a common symptom. And I think when patients tell us as doctors that they have deep pain during intercourse, then alarm bells should be ringing, and we should think that could this be endometriosis. We also know that patients can complain of pain during bowel motions or during urination. And that's because, as we've been told, it can affect these organs, the bladder as well as the rectum. Other symptoms include heavy menstrual bleeding, bleeding between periods, delay in falling pregnant, infertility, and this may be the first time that one finds out that a patient has endometriosis. When you are investigating a couple for infertility and you do your laparoscopy, that may be the very first time that we find out that the woman has got endometriosis. Other symptoms include bloating, nausea, constipation, diarrhea, and tiredness. There are extrapelvic presentations or symptoms depending on where the endometriosis is. And as you've been told, it could be anywhere in the body. Surgical wounds in the chest or in any other organs. And we know it can damage the ureter, leading to obstruction of urine. Now, the question is this: if we know the symptoms and signs, then why the delay in difficulty of diagnosing endometriosis, or why the misdiagnosis of endometriosis? Some people will say, well, I mean, you're a woman, you're having periods, what do you expect? Well, it's not something visible when women come to complain about it. We can't see it, we can't feel their pain, and perhaps because of that, people don't take them seriously, or at times do not think it could be endometriosis. Other things is that it can mimic other disease conditions, such as pelvic inflammatory disease, inflammatory bowel disease, or inflammatory IBS, irritable bowel syndrome. Now, you will see that my last point there is that we as doctors do not listen to patients. And it is important that we take this on board. Women know their bodies, and we should listen to them when they come to us. Now, the consequences, how it affects people. Pain, nobody likes to suffer from pain. Subfertility, we've mentioned. Because of the chronicity of the pain and severity, and at times no solution in sight, people could go into depression, marital problems due to what I have alluded to, and it can affect the quality of life. And there are consequences such as economic consequences. When you take time off work and you don't go to work, then you don't have an income, or even if you have a guaranteed job, that's loss of hours for the company or organization you work for. Now, I'll be talking about diagnostic modalities. History, the old taking history is very important, and after the detailed history is critical, as in the symptoms I have shown in the previous slides. And again, we mustn't forget family history because of the genetic association with genetic causation. Listen to the patients and let us show empathy. It's not just in the head of the patient, and it's not just the fact that patients are whinging or trying to get days off work. So taking their history is important, very, very important. I cannot overemphasize that. Now, one of the things is this: the correlation of the severity of symptoms does not necessarily indicate the extent of the disease. When we look into the pelvis at times, you could find extensive endometriosis and the woman hasn't got lots of pain, and vice versa. You could find very little endometriosis and the degree of pain is very severe. Now, delay in history. The UK All-Party Parliamentary Group found out that 40% of women had visited a doctor 10 times before being referred to a specialist. So what I'm trying to highlight here, as we've been told there are doctors in the audience, is the importance of primary care doctors, general practitioners, or family doctors, depending on what you call them where you are. The diagnostic modalities, when you undertake an examination of the pelvis, you could elicit deep pain. You could feel nodules in the pouch in the diagram that was shown previously. The uterus, the womb of the woman, could be fixed and painful. And you may also be able to palpate, or that is feel an abdominal or pelvic mass. Now, in my practice, one of the diagnostic modalities I offer is to say, well, haven't listened to you. This sounds like endometriosis. I do know that the gold standard of making a diagnosis is a laparoscopy, that is keyhole surgery, to have a look inside. But that is not without potential serious complications. And we do what we call an empirical approach, in which you may offer the pill, which is taken continuously to create what looks like a false menopause, or using Zoladex or Prostap to stop the period altogether. And if the patient comes back after treatment saying, oh, I feel better, my pain is gone, then you might say, well, haven't had this short-term treatment, let's treat you for up to 6 months because you've responded to therapy. Other diagnostic modalities, like I said, keyhole surgery, that's the gold standard. And you've seen that picture before of the burnt matchstick appearance. So I wouldn't go too furthermore into that because we've seen that before. Now, these are current techniques to diagnose as well as assess the severity of the disease. A transvaginal scan, where you may see plaques or nodules. And this requires skill in order to do this, or order to read the imaging. MRI is something that is coming into play at the moment. And again, you have to be trained to undertake this procedure as well as interpret it. The picture on the bottom of the slide are MRI images. So just to summarize what we've been saying, the disease presentation clinically can be challenging to clinicians. I'm appealing that we listen to patients and that early diagnosis and referral to a specialist is important. And this can be achieved by taking a detailed history, a thorough physical examination, and undertaking the appropriate and relevant laboratory investigations. So a heightened awareness is important. And where is the role of the patient in all of this? If you are not getting any headway with your doctor, ask the question, could this be endometriosis? Because we as doctors, we're human, we may not have thought about it, but when you drop hints to us, then we might say, oh, I haven't thought about that. Perhaps it is. And then we do what is necessary. But if you're not getting a headway, you can always ask for a second opinion or go for a second opinion with another practitioner. I will suggest that further research is required to understand this disease, what causes it, how to diagnose it early, and what effective treatment modalities that we can give to women. That is my talk, but lest we forget, I just want to remind each and every one of us we're in a pandemic. Please, let's believe in it, that it's real, and undertake the necessary measures. And if offered the vaccine, consider, and I stress, consider taking it. Thank you for listening.
Thank you very much, Prof. So I think the next speaker will be Alex, Dr. Alex Oboh. I think I've seen him, so he should be here. Do you mind? I think he needs to share his slide. So do you mind, Dr. Prof, are you still? No, you've come up.
No,
okay,
I've come up.
Yeah, so Alex, please, can you do your presentation, please?
In the meantime, I just introduce myself while I'm trying to go through all this. My name is Alex Edosa. I'm a consultant gynecologist who got nothing to declare. I currently work at the Mid-Yorkshire NHS Trust as a gynecologist in the Endometriosis Center. The only thing I've got to declare is that I think I had my house job with Dr. Alabi many centuries ago, where we all trained together at the Lagos maternity hospitals. So if I can get my slide, it should share now.
I think that's
good.
Not all.
Can you
Alex.
see my slide, everybody?
Yeah, Alex, that's not all.
Yes, and we did a training together in Yorkshire before he ran away to join Manchester United, and he moved to the Manchester Axis, and he abandoned me in this cold place.
All right, thank you.
We kept in touch. Can you hear me? Can you see my slides, everybody?
Yes, we can. Yes.
Okay, so good. John, thank you very much for the invite to share my experience and knowledge with your audience in Nigeria and wherever you're joining from the rest of the world. I think my thoughts is that I will be speaking today to gynecologists, to patients, relatives, and some family doctors. So my talk, it's not all science-based, it's quite generic. So it's something that everybody hopefully gets something out of it. And I'm hoping today, he's asked me to talk about treatment options for women with endometriosis, but I'm going to talk briefly on the types of endometriosis, then we can walk about how to treat women with endometriosis. And I'm going to end with giving some scenarios and trying to explain how I would manage these patients with endometriosis. And I'll be happy to listen to your questions on how you do things differently. So my colleagues before me have discussed about the types of endometriosis. And like Dr. Folarin said, it's still, out there where we're still having discussions about how many types of endometriosis do you have. It's peritoneal endometriosis, the same as the deep infiltrating endometriosis. It's the same as ovarian endometriosis. The pathophysiology or the etiology, looking at the genes of these genetics of these diseases, is still quite variable, because there's a big school of thought that says peritoneal endometriosis is quite different from the deep infiltrating disease and also different from the ovarian endometriosis. So I tend to agree to use the word different manifestations. You can have endometriosis manifesting on the peritoneal surface within the pelvis and the abdomen. You can have the deep infiltrating endometriosis between the spaces between the rectum and the vagina, and with the bowel being stuck around that too. Or you could have endometriosis that just localized in the ovaries. The uterine endometriosis, the adenomyosis, which we know, which is still in the same spectrum as the deep infiltrating endometriosis. And more worrisome for us as endometriosis gynecologists, and more challenging for the patient, is the extragenital endometriosis, where I've had patients who've got thoracic endometriosis in the Yorkshire region, and sadly we've got no cardiothoracic surgeon who's interested in dealing with women with thoracic endometriosis. I'm looking at sending them down to Cambridge or sending them to the London Axis for assessment by the cardiothoracic surgeons. So it's quite a challenge for us, and we still don't have all the answers. Dr. Folarin said the same thing as Dr. Jaiyesimi. So what's peritoneal endometriosis? I put a picture here. I hope you can all see that. And it's when you have endometriotic implants on the peritoneal surfaces, and the histological diagnosis would be it's less than 5 millimeter depth, so you can easily peel that off the peritoneal surface, and hopefully you get a total clearance of the disease. You've got these burnt out lesions, which is supposed to be a part of the spectrum of development from the hemorrhagic spots. When you get established, you get the burnt out black spots. And finally, when you're well established, you now have these white plaques on the peritoneal skin. You can have deep infiltrating disease, and the deep infiltrating disease in this slide, it's not the black spots on the left of the picture, but more of the middle. What you can see is the rectum being pulled up to the back wall of the vagina and the cervix. You have this dimple in there. And what's interesting is if you try and open that without the necessary surgical skills, you would create a hole in this woman's rectum or the vagina. And if that's not recognized or properly managed, she runs a higher risk of developing peritonitis, from fecal peritonitis, and potentially she could run into trouble, which could have long-term impact on her health and well-being if she survives it. Most women will survive it if you pick them up early and manage them, but the recovery period is quite a turbulent month for these patients. So it's important to pick that up. I chose to use this slide and not to use this slide where the pouch of Douglas is all covered up. And that's very easy when you have an obliterate pouch of Douglas for you to be scared, oh my God, she's got deep disease. But this is actually more dangerous because this is deep disease, but it looks as if she's got a clear pouch of Douglas. So be very careful about that. Ovarian endometriosis, and it's when you have the disease in both ovaries. I've got a picture here with 2 ovaries distended with endometriosis, and you're going to find this, it's going to be a challenge for a young woman, especially a young woman who hasn't completed a family. So it's important you recognize that and you can think of how best to manage it. So what are the treatment options for a woman with endometriosis? My approach, and in the hospital I work with, which is a regional center, what we try and do is have a holistic care for women with endometriosis. We aim to establish a partnership between the patient and ourselves, and we hopefully try and negotiate a healthcare plan with the patient that helps her towards recovery. I think that's very important because it all starts with making the right diagnosis. Dr. Jaiyesimi has talked about the women's journey, where it takes about 6 to 8 years to make a diagnosis, and she comes to you. And the classic story you always hear from this patient is, nobody believed me. Either the GPs didn't believe them, or even the gynecologist didn't believe them. And it is quite sad, but it's the reality. And I think we, in 21st century now, we need to do better. And I think we are doing better. So it's about taking your history. Clinical examination is important. But except you've got severe disease, the chances are likely the clinical examination will be normal. So the fact that a woman has heavy, painful periods, you've done a biomarker examination, uterus is mobile, she's got some tenderness, she hasn't got any pelvic infection, you think, oh, she's making it, she hasn't got endometriosis. It doesn't help, because we know that the sensitivity or the specificity of clinical examination isn't 100%. So for most patients, I would want to scan them and say, okay, how much information would the scan offer to me? The pelvic ultrasound scan is quite good, or it's very good if they've got ovarian endometriosis. I don't expect with a good ultrasound scan machine, you will miss ovarian endometriosis. That should be a bygone era for us. But if they've got peritoneal disease, it is very likely you will miss it, because the abdo or transvaginal scan isn't designed to pick up. It can't even pick up peritoneal disease, because somebody could be very subtle. They're about 3 millimeters, 5 millimeters, you won't pick that. But if you have well-established, deep infiltrating endometriosis, you should pick that up if you're very good at scanning. For patients, should they need to have an MRI scan? If you've got a good sonographer who can do transvaginal scan, or if you're good at it, then you really don't need to do an MRI scan. We would do an MRI scan for patients once we found they've got deep infiltrating disease. We either almost like we've scoped them before that, we picked that up, and to help us plan their long-term care, which may involve bowel disease and bowel resection. So I need to know, for example, I've scoped her, she's got deep infiltrating disease. How much bowel involvement has she got? Can I treat her by just shaving the disease of the bowel? How do I know that? And to prepare for that, if you get an MRI scan, it can map out how much of the bowel is involved. Because some of them may have PRO bleeding, that's rectal bleeding. If you've got rectal bleeding, you got to do a sigmoidoscopy first to make sure they haven't got any lesions within their large bowel. And even that's negative, the MRI scan gives you the benefit to see how deep is the disease. Has it gone through the serosal layer of the bowel into the muscularis layer, which you can only pick up by MRI scan. A laparoscopy wouldn't give you that. The gold standard we know to make a proper diagnosis, you biopsy it, you get a histology, and you can confirm that yes, you got endometriosis, and you can help manage the woman. Because sometimes you can scope person, I think I've got a white lesion there, she may have endometriosis. Our practice is we will take a biopsy of it and confirm that and have a formal conversation. Because sticking the label on endometriosis on a patient could be lifelong for them. So I tend to want to get a proper diagnosis, a histology to back that up before we can stick that label to the patient. So GIRFT, it's an acronym we use in the NHS. It means getting it right the first time. I think that's very important when in our unit, when we manage remote endometriosis, and it's something I would strongly recommend to everybody who's a gynecologist in the audience there. Because if you get it right the first time, it's more likely you get a buy-in from the patient, you get their trust, which is very, very important. And then the patient hopefully will get a better outcome. Because one thing everybody knows, we don't have a cure for endometriosis. So you're not going to be a superstar hero, then I'm going to cure you. We don't have a cure. You need to follow this patient in the journey through managing her symptoms and hopefully getting a good quality of life for the patient. And that's what I agree with my patient. We're going to cure, but we're hopefully going to improve your quality of life, which we know the science supports. So she's got endometriosis. The question is, what needs to be treated? Could they come into you with either pain, they've got infertility, or they've got both? So if she's got pain, can I manage the pain? Is that her priority? Last week in my clinic, I had a patient who was 42, never had kids, had a scan, severe endometriosis, deep infiltrating disease. She's had a myelina coiling for last 2 years, minimal periods, manageable pain. She's just quite happy to know that, well, I've got DIE, my pain is well controlled. I don't do anything else. I don't have children. I'm happy. Whilst you have some other patients, their priorities about dealing with infertility. And if your priority is infertility, as an endometriosis surgeon, I'm not a fertility specialist. I need to refer on. If she's been trying for a while, for more than 12 months, I need to refer on. It makes no sense to the patient for me to keep her in as a fertility specialist or try and manage her fertility. I'm not. So it's about finding who the expert is who can help her. And that's how you join the patient in the journey. If you decide she needs to have treatment, the question is, do we offer medical treatment or do we offer her surgery for treatment? And we'll talk about that. But the key thing for me, and I think that's where medicine should be with the 21st century. And in the UK, we've got the Montgomery's trial report, the results, which has changed how we practice medicine. It's no longer about you, the doctor, being the boss. Okay, we've gone past that stage, and I think Nigeria is catching up quickly, and we should embrace it. It's about making the patient share the decision with you. And to share the decision, she has to be given all the necessary information to make that decision. And that's key. The analogy I tell my patient is, could you imagine if you want to buy a car in Nigeria? Yeah, you've got loads of money, but you still want to know what kind of car you want to buy, how fast it's going to go, how much is insurance on the car, how much is it going to take to run the car every year. You want to know things about it. Then you can weigh, should I buy the Mercedes, should I buy the Volvo? Then you make a decision. But you just don't buy the car because the salesman says you must buy this is the best car for you. And the same thing we need to apply to managing patients with endometriosis. It's what are the risks or what are the benefits of each treatment option? So if I'm going to offer you medical treatment for endometriosis, what is the expected outcome for you? And what are the risks of having this medical treatment? What about surgery? Yes, I'm a good surgeon. I can operate on you. But that's me. That's my ego thing. What's the benefit to you? Are you just going to be part of my numbers that have operated on you? Or you're going to get away with some benefits? That's very important for the patient. And lastly, where is the right place for treating this patient? In the UK, we will agree if a woman's got severe endometriosis, which is a deep infiltrating disease, she needs to be referred onto a regional center. It's no longer acceptable for you to do it in your local teaching hospital or district general hospital if you're not a regional center. And the reason it's there, patients get the best results if they're managed by people who have more exposure, do more cases, and are more experienced in dealing with these diseases. And I would strongly encourage you to do the same thing in Nigeria. I know Dr. Alabi, he's doing a lot of laparoscopic work. He's quite good at what he does. And there's nothing wrong in another gynecologist who can make a diagnosis by laparoscopy, but thinks that this disease is way beyond my level. Should I be handing it over to another gynecologist? That's the way we should be moving forward, where it's about making the patient understand, I can make a diagnosis for you. If you got mild disease, I could offer you treatment. But with severe disease, I need to be passing you on to some other person. So I strongly encourage Jiwo and other people in Nigeria to build a network so we can know who can do what level of endometriosis. So you know where to send the patients to. And you're not going to be losing patients, you're not going to be losing money because there is enough space in the air for every bird to fly. So you get lots of patients with endometriosis and everybody's going to have enough to treat and run your service. Dr. Jaiyesimi talks about the fact that with endometriosis, 10% of women would have it. Last time I checked Nigerian data, we've got about 200 million people. Half of them are women. Reproductive age would be about 60% of our women being reproductive age between 15 and 49. So 60% of 100 million women, you got 60 million women. 10% have endometriosis. You got 6 million every year. So there's loads for everybody to treat. So it shouldn't be a problem about wanting to have, I must have the patients to myself. It's more about the patient getting the right treatment. So let's talk about medical options. So you can take the non-hormonal treatment, such as your non-steroidal anti-inflammatory drugs. I don't know what the names you have in Nigeria. You have Voltarol, ibuprofen, you have paracetamol, codeine, tramadol. But just be very wary. The opioids, the tramadols, they're drugs of addiction. So if you're starting patients on this, you've got to have that conversation. She can get stronger and stuck onto those drugs. I need time to wean them off it. There's some emphasis now about Chinese herbal remedies helping out. I think there's a Cochrane database review on that, which is there is some evidence that the quality of the studies are very poor. The emphasis for us in the UK is about using hormonal treatment. And the principles of this is the endometriotic implants are usually estrogen dependent. They've got lots of estrogen receptors. So if you can suppress the estrogen to these lesions or antagonize estrogen production within the woman's system, you can help burn out this disease and help relieve the patient's of their pain. And that's the principle which the combined pill works. The combined pill suppresses endogenous estrogen production. And so the progesterone in the combined pill counteracts at the receptor level the estrogen receptor. So the estrogen in the pill doesn't have the same effect as the endogenous estrogen would do. And so progestins work. So you can give high doses testosterone, you can give the Depo-Provera, you can use the Mirena IUS. They all work in the same principles. The gonadotropin releasing hormone analogs such as Prostab, Zoladex, and that's the same way they work. More recently, people have been trying the aromatase inhibitors, letrozole, which some of you know and use for subfertility treatment. And it's been shown to antagonize the estrogen production within the implant, so they have a burnout. But all of these drugs are great. They've been known to reduce pain in women. And Dr. Jaiyesimi alluded to this, that you can use the gonadotropin-releasing hormone analogs as an empirical test to see if she's got endometriosis. Today, I had a woman in my clinic this morning who's got a BMR 53 and GP thinks she's got endometriosis. She believes she's got endometriosis. So I've got an option of either scoping her, but she's got asthma, COPD, sleep apnea. So I know she will struggle with general anesthesia. With a BMR 53, weigh about 127 kilograms, that's going to be a challenge. So like Dr. Jaiyesimi alluded to, she's going to have an empirical treatment with the analogs. If I can get rid of her pain with that, it tells me she may have endometriosis, and we can sit down and think of how best to manage her going forward. But if the pain is still there, despite complete ovarian suppression, then it's likely there's some other pelvic organ or some musculoskeletal issues causing the pain. So I can have a diagnosis and save the patient's life. So we would use gonadotropin hormone analog for some patients where the combined pill or the Depo-Provera or the Mirena hasn't worked. All of them have side effects, and that's the biggest challenge with medical treatment. With the pill, women worried about the mood changes, the fluid retention, the breast tenderness, or some people have irregular periods with it. And yes, all the progestins would increase your body weight, which is a challenge for women. And I don't know about the Nigerian women, but the women in the UK, they're very conscious about how well they look and how well they fit into dress is very important to them. Even more important than the pain, that they look well. It's important you take that into recognition. Prostab or Zoladex will create medical menopause. And it's important the patient understands that, because they come with side effects of hot flushes and sweats, and they can have mood changes with it. The manufacturers have a license for 6 months. So if you're using it more than 6 months, it's out of license. And you're allowed to do that, because legally, as long as the patient has tried other options and this is the thing that works for her, you're allowed to start them on this treatment. So it's an off-label treatment, which has to have an agreement between the patient and yourself. If you're going to use it for long-term, more than 6 months, you've got to consider giving this patient add-back therapy, because that helps the patients to hopefully control the side effects of bone thinning. And they all have impact on fertility, because these patients will not be able to get pregnant whilst in this treatment. So if you compare them relative to each other, this slide shows that they all work. And if you compare to placebo, they all work, and compared to each other, they're about the same. So it's about what suits your patient. For surgical treatment options, I put this slide there because if you look at the Cochrane database recently, they've talked about the fact that if you look at the quality of evidence, they're poor, that surgery makes no difference. But in the BMJ recently, we've been able to show from the BSG database that there is a significant improvement in quality of life for these patients. I think I'm running out of time, so I'm going to quickly run through things for now. So for surgical treatment options, I have the option of either laparoscopic excision of all the endometriosis you can see, reduce adhesions in the patient, trying to restore the anatomy, helps to reduce the pain. So for some patient, it's just laparoscopic excision of endometriosis. Others, you may want to add a hysterectomy to it, or even had removal of the ovaries. And I put this slide to help you guide how you make your decisions. Because this is a study which we tend to use, and our data and our local hospital matches it up also. If the disease-free interval for the patient is important, they're not going to be cured. So if you're less than 30 and you have a laparoscopic excision for endometriosis, over 2 years, you have a 63% that will be disease-free. So 40% may have a repeat surgery. If you're about 30 to 39, 20% may have repeat surgery within 2 years. And if you're over 40, that goes about 15%. Over 5 years, if you took out the ovaries of women over 30, you get more of a benefit if you're over 40. So we tend to be more reluctant to take out the ovaries until you get over 40, because that's where you get some benefit. Taking it out earlier, the first 2 years, you may be disease-free, or you may have a reoccurrence of your symptoms of pain and require surgery within 5 years. So with endometrioma, the option is about you take out the cyst, so you just open it and ablate the cyst. But the key thing is whatever you do is going to have an impact on your ovarian reserves. and there is a 10 to 30% reoccurrence risk for these patients. So very quickly, I'm going to just use, because I'm running out of time, I was going to look at these cases to discuss it, and the cases are just to show you where you can make different decisions. So the first case, you get a 28-year-old woman who's had one child, and main symptoms are pain and pain with sex. Your laparoscopy confirms this. Yes, you can offer her excision treatment. You can excise the disease for her. She's 28. You know that in the next couple of years, she's mostly going to be pain-free, but there's a 40% chance she may come back and have a repeat surgery. So that's pretty straightforward. And if a problem in this case is pain and fertility, if she's been trying for, say, 2 years to achieve a pregnancy, the evidence shows that if you took out this endometriosis, you get a better outcome for spontaneous pregnancy. And even going forward to have IVF, you will have a better outcome for these patients. A patient, case 2 is a woman who's 36. She's had 3 children. She's got large bilateral ovarian endometrioma. You confirm this. If her main symptoms here are dealing with pain, if you do bilateral cystectomies, because she's young, you want to save her ovaries, you can take out all endometriosis as you can take out, you will improve her pain symptom. Yes, in the next 5 years, she's got close to 20% chance she may have a repeat surgery, but she can hopefully pain-free for that time period. And you may want to consider medical treatment with that. If, on the other hand, she's 36 and has had no children, you got to think carefully here. If I took out the cyst in the ovaries here, I'm going to reduce her ovarian reserve. At 36, naturally, she also has reduced ovarian reserve. So you want to consider, do I want to check her AMH first to look at what the ovarian reserves are? My practice has been to get her to speak to an IVF specialist. We can go through things, because we know that if the cyst is less than 3 centimeters, having surgery doesn't improve the IVF outcome. If it's more than 3 centimeters, yes, having surgery may improve the IVF outcome, but she needs to have a conversation first with IVF specialists. Because what you don't want to do is offer her surgery and you take away what's left of her ovarian reserves, and she now has subfertility that she requires to have a donor egg. It's important to have that conversation with the patient. And finally, we talked briefly about this deep infiltrating disease. It's about getting her referred to a regional center for management. So in summary, we've talked about the different types of endometriosis, the treatment options for the patient, and my strong emphasis, my take-home message is try and have a holistic care to managing your patients. Thank you very much.
Thank you very much.
So again, thank you very much for asking me to come and speak on this, one of my favorite topics. And I have, because I'm on call this weekend, I have pre-recorded my talk. So hopefully it goes seamless. I'm just going to share my screen and hopefully the movie will start. Good afternoon. And I would like to take this opportunity to thank Dr. Alabi and South Shore Women's and Children's Hospital for inviting me to talk on one of my most favorite topics of endometriosis in order to raise awareness of endometriosis within the community. My remit today is to talk about the experience of endometriosis centers in the management of women with endometriosis. I think most importantly, it's a matter of setting standards for the management of women with endometriosis to ensure that the right patient has the right operation by the right surgeon for the right reason at the right time. And I think this has to be based on the informed consent principles, having defined the objectives between the carer and the patient who is suffering from endometriosis, giving consideration to future fertility and the risk of recurrence from surgery. And I think the basis of this is imparting information such that the woman knows what is happening. She's given a detailed history and had an examination, and on the basis of her investigations, she is aware of the stage of her endometriosis and the implications of that would have on her quality of life, fertility, and what would happen if she were to have an operation. I think we just have to remind ourselves about the epidemiology of endometriosis, knowing that it is prevalent in about 5 to 10% of the general population. And that means in any population, irrespective of race, and the incidence would increase depending on where you look for it. One of the reasons why endometriosis centers are so important is because of the potential for delay in diagnosis. There are very many women who will go off to their doctors, give a history, have an examination, but then will be told at the end of it that just having painful periods is normal. And I would just suggest that if that is the case, then the women would just need to change their doctor. The delay in diagnosis comes from various things. It depends on the knowledge of the doctors. It depends on the type of symptoms. It also depends on local pressure groups and the degree of awareness that there is within the local population, and of course the local facilities that are available. And like I said before, irrespective of what population you look in, endometriosis exists. One of the other considerations that need to be taken into consideration, particularly for endometriosis centres, are the changing demographics. In modern societies, women tend to delay childbearing, often on oral contraceptive pills, which can mask the symptoms of endometriosis. But having said that, an early diagnosis is always best. The magic age is usually about 35, such that women can make up their minds as to when they need to start having a family. The younger that they are when they try to get pregnant, the more likely it is that they're going to be able to do so. It is also needed, we also need to remember that the first operation that women have is usually the best operation because of the risk of recurrence. And things that need to be taken into consideration, particularly from the endometriosis center point of view, is the risk of having surgery, the impact the surgery will have on ovarian reserve, the impact of possible incomplete surgery, and women don't necessarily have to worry about the learning curve of their surgeon in endometriosis centers, and we'll come on to that a little bit later on. Triage towards an endometriosis center should start from diagnosis. Based on the history often, women should be referred. And if we have an MRI and an ultrasound scan which shows kissing ovaries, then it is more than likely that there will be bowel involvement, and it is more than likely that these women will benefit from endometriosis center treatment. Then having looked at this recent study from Leonardi and colleagues, even when women don't have kissing ovaries, there is still a chance that they would have deep infiltrating endometriosis or obliteration of the pouch of Douglas, which is that bit between the uterus and the bowel. So based on history and examination, irrespective of ultrasound scan, women are always possibly best seen in endometriosis centers so that adequate diagnosis and treatment is possible. Even when women have laparoscopy in non-endometriosis centers, the thing to do under those circumstances would just be to take the pictures, send them on to endometriosis centers without disruption, so that they can benefit from the expertise that is available in endometriosis centers. The other argument for endometriosis centers is the fact that we now know that excision is better than ablation for all stages of endometriosis. It reduces the risk of recurrence. It is better for pain. And there are certain studies that show it is better for fertility. And it often requires a person who's actually trained in laparoscopic surgery for the excision of endometriosis, because it may be that ureterolysis, separating the ureters from the field of surgery, is often required. So this is the first publication that comes from an endometriosis center-based population. And in this particular study, based on the endometriosis centers in the UK, it did find that for rectovaginal disease, in these particular centers, women did very well. The only criticism of this particular paper is the fact that there were no controls. But for surgical trials, surgical controls are not always available. In other countries also, like this is a French paper that was published in 2016, it has been shown that setting criteria for the excision of endometriosis improves the outcome of surgery for women. Because basically what needs to happen is that there needs to be an MDT approach where professionals actually sit down and talk about those symptoms with the woman to decide on whether surgery is necessary to start with, and if surgery is necessary, to make sure that the right people are available for surgery for endometriosis, and that these people are aware of those complications, possible complications, and those are catered in to the consent process. So the standards usually are, particularly for the BSG badge, which is the British Society of Endoscopy badged endometriosis, is the fact that each surgeon has to do at least 12 cases a year and submit a video to make sure that they are up to scratch as they continue to manage women with endometriosis. We also have to have a defined radiologist, and that radiologist is either skilled in MRIs, ultrasound, and there is a transvaginal or transrectal ultrasound that is done for these women within the centers. We have dedicated general surgeons who are trained in endometriosis surgery, because you might find that you'd have cancer surgeons, cancer laparoscopic surgeons, but cancer surgery is very different from surgery with endometriosis. We have dedicated urologists who are able to assist with bladder or ureteric endometriosis, and on occasion will be able to advise if kidneys are involved. We have dedicated pain specialists and physiotherapists who will be able to manage before and after surgery in terms of possible pain trigger points. There are also psychologists that are attached to these units that will help women who need CBT, cognitive behavioral therapy management, as and when required. So talking about rarer forms of endometriosis, there is now a move towards, for thoracic endometriosis within the UK, for instance, to provide 2 particular centres that will be able to deal with thoracic endometriosis. Other rare forms of endometriosis are things like bladder surgery, and they take place in endometriosis centres as required. And like we say, all of the endometriosis centres have to report back to the BSG and submit the outcomes of surgery. They have a dedicated CNS who is attached to them, who ensure that the patients are followed up long-term for at least 2 years in most cases. So this is just a short video looking at bladder endometriosis. This is what it looks like in cystoscopy. You can see the brown points. This is a diagnostic laparoscopy which shows the potential for bowel involvement. I think the important thing to do is to do a survey. So there's looking down for any other endometriosis that we might find. And I'll just fast forward the video for cause of time. And that is how an excision of a bladder nodule will take place. So in summary, I think the first thing is to first do no harm. And I think the first thing also is to make sure that women are adequately counselled. And usually the adequacy of that counselling comes from people who are actually trained in the art and science of dealing with endometriosis. It is only in those ways that women can have informed consent for the type of surgery that they need. These are best done in endometriosis centres where the quality of life thereafter is documented and ensured. The other issue that sometimes develops is for women who actually do need to live with endometriosis-like symptoms, they are also catered for, as surgery is not the be-all and end-all of the management of women with endometriosis. Questions, please. Thank you for listening.
Okay, so my name is Dr. Juwon Alabi. I'm the host of this event. I'm the MD and CEO of South Shore Women's and Children Hospital, Lagos. I'm taking over from my big boss. I'm taking over from my big boss, who is Dr. Jaiyesimi. And I'm just going to talk about, mine is not very clinical. It's mainly talking about endometriosis, challenges with endometriosis management in Nigeria. I don't have any conflict of interest. Obviously, like I said, I'm the organizer for the event. Now, we've heard all this today. We talk about the endometriosis treatment. We see that it's more than a gynecologist. I think now things are evolving more into multidisciplinary approach. You can use medical and surgical means to treat it. Drugs such as oral contraceptive pills, a painkiller, GnRH analogs, Zoladex, progesterones or progestogens
and most recently, elagolix and the aromatase inhibitors. Elagolix is not available. Well, it's available. It's not available in Nigeria. It's quite an expensive replacement. It's almost like giving Zoladex orally, and it's quite expensive. So it's not available in Nigeria at the moment. But I've seen a couple of patients come to me already on it. Laparoscopic surgery, like we've heard, is the gold standard. So what are the challenges in Nigeria, really? What are the... So I think the first thing is that my colleagues in the UK are very lucky because their role is to treat patients. They have nothing to do with cost and, so I've listed the challenges that I face. I'm talking about my personal, and I'm sure that talking about a lot of colleagues in Nigeria as well. So I'll start with cost, skill, infrastructure, cultural attitude, and the lack of awareness. So let's talk about cost. Cost means that, for example, in the UK, I don't think any patient pays for their treatment. It means that from they come in, they go out, their cost is totally covered. Maybe if sometimes they might pay for their prescription medication. But if they're having surgery 3-4 times or whatever, or they're going to endometriosis center where they're seeing all the specialists, is not paid for. So it means that there's a dedicated, almost insurance system that pays for them, same as the US. But yes, the US might be slightly different. But in Nigeria, in as much as they've introduced the HMO, a lot of patients are still paying out of pockets. And that's a challenge because by the time you pay for a good laparoscopy, which involves all of the above, that's a lot of money. If you need another surgery, you might have to pay for it as well. So cost is a big issue. Also maybe paying for Zoladex. Zoladex is not cheap as well. I mean, things like oral contraceptive pills, painkiller are cheap. Now, also, some of the very good centers that do extensive laparoscopy are also not listed on the HMO. So it means that a Nigerian patient might have to pay for this treatment. And even when they're listed on the HMO, I've seen HMO come to me and say, Dr. Alabi, do not offer our patients laparoscopy. They believe that laparoscopy is a choice rather than a means of treating and diagnosing conditions safely. Okay, how about the cost of setting up a minimally invasive center? A lot of centers now are still individually, it's still done by people that are passionate about this and want to develop it with no government grant, no intervention whatsoever, just a business. If you're running a business, it's likely that you will be thinking about profit. So it's not a charity, you'll be thinking about how you make your money back or how you pay your loan back. Those are challenges. And also that comes to the cost of equipment and consumable as well. I mean, my colleagues here, Dr. Jaiyesimi and Professor and Wale and Alex probably don't know the cost of harmonic scalpel. We know the cost of harmonic scalpel. We know that the cost has gone from 150,000 to almost 350,000. Harmonic is equipment you use for one patient. Now, if you're using an equipment for one patient, which is about 350,000, I think you can imagine what the cost of the surgery will be. I'm sure there are other ways you can do the surgery, but those are things that help you with the outcome of your surgery and makes it a bit less stressful. How about skills? I was lucky that I went through a training program in the UK where I was trained as a minimal access person. I went through a certification, I went through all that. But over here in Nigeria, there are no laparoscopy program. There's a general gynecology program. A lot of gynecologists are getting more interested in advanced laparoscopy and hysteroscopy, and they are finding a way to train themselves. But there's no formal training in laparoscopy in most of the training program in Nigeria. I hope that through the Association of Gynecology Endoscopic Surgery, we will be working with a lot of teaching hospitals to improve this. But right now, it's only gynecologists that self-develop themselves. And we know that the training of laparoscopy to get to the point. Now, to do laparoscopy is different, but for you to be able to do laparoscopy with endometriosis, it's a major long-term event, and a lot of people have not gone through that. Most advanced laparoscopic surgery in Nigeria are performed by private hospitals. But when I came back to Nigeria about 10 years ago, it was totally different. But I must say that a lot of people are getting more involved. A lot of the teaching hospitals are getting more. So things are changing, and I hope that it will keep on changing for the best. How about infrastructure? This is a deficiency. Ignore the double F. I think I've edited it, but I must have downloaded the unedited slide. Building a minimal access center or theater needs a lot of passion and financial dedication. To build something, you need a lot of money. So the healthcare system is not any different to any structure in Nigeria. If you look at the road, you can compare it to the healthcare. If you look at NEPA or PHCN, it's the same thing with the healthcare. If you look at the police, it's the same thing with the healthcare. It means that a lot of people that are trying to make a lot of difference in terms of trying to do activities that are almost up to standard, to international standard, may have to do this privately. And it means a lot of finance and things like that. I remember wanting to buy an equipment and I wasn't given the loan to be able to do that. So those are the challenges you face here. Technology is fast evolving. You have new technology today, tomorrow it's become obsolete. New research tells you that the equipment you were using last year is probably not usable again because the outcome is better if you use a new. So those are things that who finances that? There's a government, there's an institution, there's a government that finances healthcare in the UK and probably in the US as well. In Nigeria, they do, but to what extent? We know the budget for healthcare in Nigeria this year is almost like 47 or 47 billion naira in a population of 200 million. And most importantly as well, I think I remember towards the end of my training, that was when the endometriotic center started in the UK. That's about maybe 13 years ago. So I think hopefully we will start getting to a point where the endometriotic centers will start coming into to Nigeria as well. In South Shore, we do a lot of endometriosis surgery, but we're not a dedicated center, but that is what we are trying to, in a very short period of time, that's what we're aiming for. Now, why did I say that? If you see the list Dr. Jaiyesimi shared, now laparoscopy and treating endometriosis is not only a gynecologist, it involves a urologist, a general surgeon, and so many other people. Now, to be honest, I don't know any urologist in my vicinity that's doing laparoscopy, a local base, I don't know them. General surgeon, I've approached a few general surgeons and they're developing their skills, but they're not there yet. Now, there's some surgeons who are just like me, they came from the UK, but they are very, very active in their center and they are extremely busy people, but we're trying to speak with them to build an endometriosis center because it's very important. I'm not saying that we undertreat people. I'm just saying that out of the people you treat, some of them needs to be jointly treated by all these people. Now, how about the cultural belief in Nigeria? In Nigeria, a lot of people almost believe that pain around your period is normal. So if you have pain and you go to a hospital and the doctor is saying, I think you have endometriosis, yes, let's do the laparoscopy. I can bet you that a lot of patients will first run away. They will discuss with their family. They will say, that doctor just wants to collect money from you. It's normal. I had this when I was younger and stuff like that. Now, what does that mean? It means that sometimes a lot of these people that you could manage a lot earlier, there's a delay in treatment, meaning that by the time they come to you, to be honest, I see a lot of stage 4 endometriosis. And when you look at the history, these are people, maybe they might have been operated on somewhere when they're younger, they've done an open surgery. And I asked them, did they tell you the kind of cyst you have? No, they just removed the cyst. Laparotomy, on the other hand, causes a lot of problem. By the time you're seeing them, you almost cannot see the pouch of dog. You can't see anything. There's bowel everywhere, and the person has endometriosis. How about awareness between doctors and patients? I think we all know that initially, a lot of people here, a lot of doctors in Nigeria believe that endometriosis is not common in Africa. But that's probably because they did not have the equipment to diagnose them. In the 80s, 90s, nobody talks about endometriosis, but it's coming up now, and we know that it's not true. We did a study here, and because our study, our people that I do laparoscopy on probably were referred to me either for pain, for fertility. The percentage of endometriosis we saw, or the incidence, is about 20% in all the laparoscopy we did. So it's slightly more than the average in general population, but we know that that is skewed because we have a high concentration of people with endometriosis or pelvic pain. Okay, so driven by many factors, I wanted to put factors: lack of skill, minimal awareness by doctors, lack of equipment to diagnose. As the world is becoming a global village, there are more interaction with people all over the world. Now, patients are not only dealing with Nigerian doctors anymore. They can call a doctor from anywhere on their phone and say, "Doctor, I have this pelvic pain," or a pelvic pain, as your doctor told you about endometriosis. So I think it's important that Nigerian doctors start understanding that this is happening. It's almost like a global village now. And it's also important that doctors and patients start sharing their experience. Patient also needs to start asking questions. They need to start asking doctors questions. How many of these procedures have you done? What are your, is there anybody that I can speak with that you've done this surgery on, and stuff like that? They need to start asking questions. Sometimes by the time we get patients, it's already, they've done 1 or 2 surgeries, and you do a laparoscopy, and the bowel, you can't even see the womb because there's bowel all over. Now, I enjoyed one of Dr. Jaiyesimi's slide, which is do no harm. When sometimes you put a laparoscopy in and you see extremely bad adhesions, and you come out and tell the patient that if I progress with you, you will have bowel injury and it will be a bad outcome. Sometimes the patient are not happy, but you know that you've done the right thing because, people can die from such surgery. If you injure bowel, if you do that, then people can. So I think it's important we understand your limitations as well as surgeons. And then patient needs to understand that as well. So I think from my little experience in Nigeria, I feel that there must be a lot of training in the use of transvaginal scan by doctors and even ultrasonographers, people that scan patients. I think scanning must be incorporated into the training of gynecologists so that they know how to scan. I was lucky. I got my scanning program done at the later part of my training in the UK. I think I was a senior reg, then I went to Burnley, and that was where I got my scanning. And that's what I do. I scan my patient. I think we also need to start looking at creating center of excellence for endometriosis. Now, what we don't have as a private hospital, a lot of the public hospitals have it. They have urologists, they have general surgeon, they have that. So I think there needs to be a lot of collaboration between doctors and doctors, a lot of private and public. I'm not sure why I should not be operating with doctors with a teaching hospital in Lagos, Lasut, and Luth. I'm not sure why that shouldn't happen and stuff like that. So there are a lot of issues that we still need to sort out. There should also be collaboration between Nigerian-based gynecologists and gynecologists of Nigerian descent working in centers of excellence. I mean, we have Alex Oboh, who we not only did our house job together, we work in the Yorkshire region together as well, working in an endometriotic center. We have Dr. Jaiyesimi working. And we hope that Dr. Alabi cannot do everything. Dr. Alabi is happy to work with everybody that have the skill to be able to build this service, really. Now, infrastructural development, investment in equipment and building teams. I think that's very important. Building teams is extremely important. Working with urologists, working with gynecologists, even the nurses that you're working with, let them understand the trauma of this disease and what to do when people call and say, I'm in severe pain. Also counselors as well, and sometimes even bringing pain experts into the equation. And also to continue to work with people, advocates, to increase awareness, especially with the mantra that painful period is not normal. I think we need to change that. Extremely painful period is not normal. Whether you are, I've seen a 13-year-old here who has endometriosis, and she was started on the pill. Yes, we didn't want to do surgery, but she was told. So the younger you get them, the better. So I think it's important we start with the issue that extremely painful period is not normal. So I think with that, I'll finish my talk. Thank you very much. And I will leave here so that the next speaker can share their talk. Thank you very much.
Thank you, sir. Good afternoon, everyone. Good afternoon, the esteemed panelists, Dr. Oboh, Professor Jaiyesimi, Dr. Adewale. I'm honored to be in your midst. Thank you, Dr. John, for inviting me. Can everyone see my screen?
Yes, we can see.
Okay. So my name is Olivia Nwankudu, and I am the founder of EndoSurvivors International Foundation, which is a non-profit organization registered in Nigeria. Our mission is to raise awareness about endometriosis and promote quality care for patients. And we do that through education, research, and advocacy. So the speakers have spoken elaborately on what endometriosis is, and I think everybody agrees with me that endometriosis is a very common disease which affects 1 in 10 women, and it's not rare among women of African descent at all. Endometriosis is a disease that alters a woman's life in ways you cannot imagine. You know that with pain, peritoneal pain, with pelvic pain, back pain, and all the pain that endometriosis patients present with, not to mention infertility. All of these things come together to make living a very difficult thing. So endometriosis also impacts your mental health. It impacts your ability to work, to earn a living. It impacts on your sex life, your ability to have children. And it's, in fact, in ways that you really cannot imagine. So my talk now is just going to be about the work we've been able to do here in Nigeria. Our work is just barely 3 years old, but we've been able to do something and we're working on doing much more. So here is a picture. It says severe menstrual pain is not normal. So when Dr. Alabi was talking, he talked about the importance of raising awareness. So what we do at EndoSurvivors is to raise awareness about endometriosis, educate target audiences about endometriosis, and support women living with the condition. So as you all know, the problem with endometriosis, really, I just broke them down into 4. The first one, persistent myths and misinformation, deficient health literacy, poor information systems, and a continued lack of effective care. Actually, the myths and misinformation, health literacy deficiency, poor information systems, all feedback to result in a continued lack of effective care. So when people do not know what causes endometriosis, they do not know the origin of endometriosis. I mean, even the definition of endometriosis is a controversy. Some people say it is the presence of endometrium-like tissue. Some say it's the presence of endometrium. So there's still a controversy as to what is this thing? Is it endometrium-like or is it endometrium? So there's still that argument, and a disease you cannot define, definitely you cannot cure. However, even though there's a lot of controversy, we do agree with evidence and the body of knowledge that says endometriosis is the presence of endometrium-like tissue that is similar. And we, in fact, at the program we had in March, Endometriosis Patients Day, all of the speakers agreed that endometriosis is no longer just a pelvic disease. Endometriosis is no longer just that menstrual disorder. Endometriosis is more of a disease now that affects the immune system. It's a disease with epigenetic underpinnings. And if we do not understand this disease properly, we really cannot do much about it. So what do we do at EndoSurvivors? So it's broken down to 3 thematic areas: awareness and education. Under awareness, we have schools outreaches where we reach out to adolescent girls aged 12 to 18. We use social media to raise awareness. We use email newsletters, and we have our annual Endometriosis Patients Day where we try to bring patients and practitioners together so that patients can ask their questions. Dr. Alabi spoke extensively on the importance of patients asking questions, wanting to know the, so to speak, work experience of the surgeons. How many people have you operated on? We want to hear feedback from patients you have worked with. So we have this forum where we normally bring patients and practitioners together, and of course, other conferences. So under research, we are working on having more representation of Africa in the literature. By God's grace, by the end of this year, we'll have quite a number of publications where we're going to be representing, because the notion that endometriosis is a white woman's disease is actually an error. That's probably because we are not well represented in the literature. So we need some more doctors. I mean, we have research from Nigeria, I know we do, but there's still a whole lot that we have to do. We need to report more, especially on case reports and on how patients have improved and what works for them, and how they get better, and the kind of care that works for different patients. And thirdly, we have a support group for endometriosis patients where we provide educational, emotional, psychosocial, and financial support to endometriosis patients. So as I said earlier, endometriosis is not just menstrual pain. Endometriosis is not just inability to have a child. Endometriosis is a disease that affects every aspect of a woman's life. It affects everything. I tell you that a lot of endometriosis patients have attempted suicide in the past year, especially that last year when coronavirus was really hot. People tried, how you're not even able to go and see your parents, especially the ones that live alone. We had a number of cases of people who were actually thinking about committing suicide, because when you're living in pain, nothing really makes sense. So the reason why we raise awareness, number one of our goals is to reduce the diagnostic delay. So the speakers have, I think Dr. Jaiyesimi talked about how it takes an average of, was it 7 years or 8 years? The literature shows 7 to 10 years for a woman living with endometriosis to get a diagnosis. So we're trying to educate the little girls from age 12. That's the average age of menarche. So when a young girl starts menstruating, she has to know, what does menstruation look like? What should normal menstruation look like? So between our inception in 2017, excluding last year when we couldn't do much, we've been able to educate well over 9,000, almost 10,000 schoolgirls in Lagos and Ogun State on the symptoms of endometriosis. So we take this very seriously, because knowledge is power. And it's important for them to begin to know what menstruation looks like, what kind of pain should we begin to raise alarm about. When I don't come to school because I'm in pain, is that normal? So we teach them that severe menstrual pain, you can see this placard, this one says chronic pain, this one says chronic pelvic pain is not normal, this one says I pledge to raise awareness, severe menstrual pain is not normal. We have a lot of those slogans that we teach them to empower them and to help them to ask the right questions. It will surprise you that a lot of our schoolgirls do not know who a gynecologist is. In fact, I didn't know who a gynecologist is when I was in secondary school. So we teach them that when you're having severe pain and your GP or the first line of care, the primary health nurse or doctor is not taking your pain seriously, you can politely request, please, can I see a gynecologist? Every endometriosis patient will tell you that right from secondary school, they started experiencing menstrual pain that was debilitating, crippling, menstrual pain that interferes with your life. So if you can even get help now, not only will you save yourself the stress, the distress of living with pain, you can also, you can also help, you protect your ability to have children in future. You can also save yourself a lot of money, because by the time you're in your mid-20s, that is when endometriosis, in Nigeria, we say taigeli. That's when the endometriosis is now taigeli in your body and dress up and is ready to really mess a girl's life up. So early diagnosis is key. So we've had quite a number of outreaches. This is me speaking with some girls. And in addition to what we do, we give out sanitary pads to schoolgirls, free sanitary pads. So apart from that, we also have, for our education, so I talked about schools outreaches, social media, our Patients Day events. So here, this year, we were hosted by the British Deputy High Commissioner at the British House in Lagos. And we had a call to action conversation on endometriosis, where we had some practitioners, including Dr. Alabi, who was there, and some leading medical doctors in Lagos. We spoke about endometriosis. Different people, talked about the challenges they have. And of course, all of these things are there. We are aware of what the challenges are, the challenge with skill, challenge with funding, challenge with the knowledge base, and all of that. So the important thing now, why EndoSurvivors exists, is that we are trying to bridge the gap between where we are supposed to be and where we are now. So we know that there is a knowledge gap. We know that we have very few laparoscopic surgeons here in Nigeria. So what do we do? So the journey to what we want to become, that is the gap that EndoSurvivors is trying to fill. And to address that, we try to have conferences, we try to have roundtable discussions for different targets. We've had with nurses. Later in this year, we're having one with Radiographers Association of Nigeria. We have with different healthcare providers, just trying to fill up the knowledge gap and know, what role each person plays in order to reduce diagnostic delay and improve the quality of care for patients. So this photo here is our support group meeting last year. Dr. Juwon honored us with his presence, and that's another forum where we had an expert talking to endometriosis patients. Endometriosis patients need to, Dr. Odejimi talked about, or was it Dr. Oboh? I'm sorry, I don't know who talked about the importance of informed consent. And that resonated so well with me, because that's another thing we do. We educate patients. The support group patients are empowered patients. So we know what endometriosis is. So many of us have had failed surgeries. So we now know the telltale signs. When you're speaking with the doctor, the first 5 minutes, you already know if this doctor is a specialist or not. So in the support group, we educate one another. We invite experts to come in and educate the women there. We know, in fact, even the doctors learn quite a lot from us, because you begin to hear different people's experiences with some medications, side effects that nobody even knew about, some comorbidities with endometriosis, hypothyroidism, grave eye disease, and different presentations of endometriosis and comorbidities, which some may not have known about. So in the support group, we have a number of cases, various personalities and different women coping with endometriosis. We encourage one another, share our coping mechanisms with one another, share research with one another. Our information is evidence-based. We do not share old wives' tales or rumors. So EndoSurvivors support group is a support group. It's a very standard support group where we really, we know what's up, okay? So here is a photo of our last endometriosis Patients Day, which we had online. And yeah, it was a very impactful one. We spoke at length about extrapelvic endometriosis. So we covered quite a number of the most common presentations of extrapelvic endometriosis, the options available to women, and how they can actually cope with the disease. So here is a call to action for everyone listening. A call to action is a three-pronged approach: awareness, education, and care. So under awareness, I'm challenging you, in what ways can we heighten endometriosis awareness? So what I see in Nigeria, people just sit down and say, there's no awareness about endometriosis. Okay, so there's no awareness. What are you doing? Who is going to raise awareness for us? Who is going to do something? So I think that everybody should take the challenge. I'm challenging everyone to please do something about endometriosis. It's not easy to live your whole teenage life in pain, get to your mid-20s and you're still trying to figure out what is this thing, and then you get diagnosed. From that point on to your late 30s, pain, infertility, missed opportunities. So please, how can you heighten awareness? And I can answer the question for you. Just partner with EndoSurvivors. I'll talk more about that. So how do we educate the relevant stakeholders about endometriosis and its burden on families and societies? I've met gynecologists that will say, when she gets pregnant, she'll be fine. Or, it's not endometriosis, give her Primolux. just take Zoladex. Zoladex is not a cure for endometriosis. Primolut and hormonal tablets do not cure endometriosis. Those are band-aids. And I think that everybody should know. But it's surprising that we've seen gynecologists that think that when you get pregnant, it will go. Of course, it's true. I know someone who got pregnant and her symptoms, were relieved, but that's just one out of so many. Pregnancy is not a cure for endometriosis. So we try as much as we can to educate even medical communities about endometriosis, its burden, and the impact it has on women's lives. And thirdly, what is the future of endometriosis care in Nigeria? So we're working on standardizing healthcare, and not just standardizing it, making it accessible and equitable for patients. So what can you do? You can please follow EndoSurvivors on Instagram and Twitter, Facebook and LinkedIn. Our handle is EndoSurvivors, okay, on Instagram and Twitter. And then on Facebook and LinkedIn is EndoSurvivors International Foundation. And please donate to support all of our initiatives. You can follow and send a DM and you get all the information, or visit our website, endosurvivors.org. And thirdly, if you are dealing with endometriosis, you are not alone. We have a thriving support group. I dare say that every case of endometriosis is represented in that support group. And these are women, of very good morals. And it's not just a support group for endometriosis. We encourage one another. People get jobs even on the support group. It's a good opportunity to even network and promote your business, because that a lot of endometriosis patients are unable to have proper jobs due to pain and the debilitating nature of the disease. So you're not alone. You need a community to support you. And we have in-house mental health counselors who are just superb at what they do. So these are my references, and my slides were made with Canva for nonprofits. Thank you very much.
Okay, thank you very much, Olivia. Thanks a lot. So I just want to thank everybody that have listened so far. I think we've come to the end of all the presentation. Nigeria, thank you. Now, so I think we've come to the end of the talk. So the first thing is that I want to thank the speakers extremely well. On behalf of myself and my colleague at South Shore, we are extremely grateful for Dr. Wale Folarin from Southampton, my great professor, Jaiyesimi, that he was a professor even before I started training, I think. I think it was in the Newcastle area, I think, if I'm right. Then my honorable boss, Dr. Jaiyesimi, Olivia, thank you very much for, I'm sorry about all the time that we were disturbing you, that where are you and stuff like that, but I'm sure that, and also to myself as well and my colleague that put this together. We've been working hard for last few days to make sure that this is done. I also want to thank all the participants.
Dr. Oboh.
Oh, sorry, Dr. Alex Oboh. Yes, my great friend from house job to consultant and stuff like that. I also want to thank everybody that's participated in this. The questions are very interesting, and I have myself, I've gained a lot in this, and that's the whole idea of seminars like this, for the participants to gain and for the speakers to gain one or two things as well. So I'm grateful for the participation, which was over 100 at some point. So thank you. And at the end of this presentation, we still have a lot of people still here. So we must have been able to impact some knowledge to people, and they must have found it interesting, and that's why they're still here. Now, if you don't know South Shore, this is where I talk about South Shore. South Shore is a women's and children hospital based in Lagos. We are based in VI and Ikeja. We treat a lot of people with endometriosis. So if you want a second opinion or a third opinion, please come and see us. We hope to be a player in the establishment of a proper endometriotic center in the future. We're working towards that. And we hope to always seek opinion from our colleagues in the diaspora as well, because they are, they work in an environment where this is bread and butter to them. So we are hoping that we'll continue to collaborate with them. So on behalf of South Shore, I want to say thank you again. And hopefully we will see you soon for another seminar. Thank you very much. And have a wonderful weekend.
Bye.
Thank you.
All right, bye everybody.
Bye everybody.
Thank you, Dr. Folarin, Dr. Jaiyesimi.
Thank you,
Professor
Olivia, as
Jaiyesimi,
well.
Dr. Oboh, nice meeting you all. Thank
Nice
you.
meeting you too.
Funlayo, nice seeing you again.
All right. Thanks, Joan.
And Prof,
Thank you.
thank you. All right, bye.